Good afternoon, Ryan Liabenow here. Hope you're all doing well. Want to address reduction in reimbursements in the independent pharmacy space. You really have four issues that are going on. Number one, DIR fees. That's obviously specific to Medicare and Medicaid. And Medicare and Medicaid specifically had the intention of that being a reconciliation of claims payments. Now PBMs are using it as a catch-all to take money back, particularly from independent pharmacies. Number two, you have copay clawbacks, and that's when PBMs are requesting that independent pharmacies collect an inflated copay. Bad for the independent pharmacy. Bad for the patient, really good for the PBM because they're picking up the access. Number three, you have the issue of maximum allowable cost adjustments in the generic space. Obviously, we know that that's negatively impacting independent pharmacies as well. If you actually look at if there's 100 generic drugs dispensed at an independent pharmacy, 15 of those drugs every single time will be negatively reimbursed. Isn't that insane? I am going to buy a generic drug from Mckesson, Amerisource, Berg and Cardinal Health, whoever the wholesaler might be, and the PBM is going to pay me less than I had to pay wholesale for that drug. That's crazy. And then obviously you have GER, or generic effective rate adjustments, that are negatively impacting independent pharmacies. And I want benefit advisors, particularly in the commercial health plan space, to really get their facts straight. And I say that with love. I want to be an educational resource for you, but we need to understand that even when you're deploying a prescription drug program with a really great PBM, they're leasing national networks. They're using the Optum networks. They're using the CVS Caremark Express Scripts model in the open network, right, for access purposes. So those same tricks of the trade that we're talking crap about and saying PBMs are doing horrible things to our self-funded employers, you're actually deploying those same resources just with a different PBM. And what's happening is as you say you want to localize healthcare, you're deploying resources that are actually putting those independent pharmacies out of business. So localizing healthcare, restoring community pharmacy has to be aligned with creating independent pharmacy networks in your local community that guarantee positive reimbursement for independent pharmacies. Hear me. Guarantee positive reimbursement for independent pharmacy. So if you're a PBM that will not deploy a copay clawback, will not deploy MAC adjustments, will not deploy GER, call me. We'll do business. But I don't think that exists. Except with us, where we're actually setting up narrow networks specific for independent pharmacies where we get rid of all of that and we guarantee positive reimbursement and give those independent pharmacies the tools to be able to go to direct. And not just direct with commercial health plans, folks. Independent pharmacies, hear me. You can go direct with these administrative resources to long-term care facilities, hospice, skilled nursing facilities. You can set up 340B contract pharmacy networks where you're preferred for 340B hospitals and health centers. You got to take control of your destiny. We need to get the facts straight. So with that said, I'll look forward to explaining more later on. Thanks so much. Bye.